My name is Neil Diegelman. I'm an attorney here at the law offices of Melissa Day. We're here with Suki, who is also presenting with me in Lawyers and Friends, episode 36.
Things keep changing and never for the best, at least not for you. Rearranging rules that we cannot contest. What can you do? Don't go crazy when the judge says your claimant had a good day. When things look hazy, 'cause there's nothing left of 25A. Don't get angry, get mad today. We're gonna help you through it all the way. It's never easy, it's never fair. You can't find any reason anywhere. And if you're ever at your wit's end, we are here for you, our friends. Don't go crazy when the judge says your claimant had a good day. When things look hazy, 'cause there's nothing left of 25A. Don't get angry, get mad today. We're gonna help you through it all, 'cause you, my friends, are beautiful. We're gonna get you through it all the way.
Hey, all right, that's always one of my favorites. Today we are here. The title of the episode is Full Steam Ahead, All Aboard for Onboard and the new Medical Treatment Guidelines. And we're also going to be discussing the already existing medical guidelines, but not in as much detail. So, just a second. Huh. Little technical difficulty here.
Slides won't start.
Yeah, it said PowerPoint had a problem. So just 1 second. I'm sorry about that. Sorry about that, everybody. Starting up again. Yeah. Okay. Great. So, introduction to Onboard. I'm sure many people are familiar with this system already, but it's a new online information system that the board is building to completely replace the paper-based claim system with a single web-based platform allowing for paperless transactions and a user-friendly interface. Onboard will be a better system for a better board. The OBLR, the onboard loading, is the first phase of the onboard, and it's designed to move several key phases of healthcare providers and insurance from paper to online. It includes prior authorization requests, which we'll be discussing as PARs, for treatment that falls outside the medical treatment guidelines and other variances, as well as submission for requests for unpaid medical bills. It's rolled out in 3 phases, all of which are already in place. Phase 1 was for medication PARs. That was on March 7, 2022. Phase 2 was durable medical equipment, and that was April 4th, 2022. Phase 3 is treatment testing PARs, and that was May 2022. Briefly, phase 1, again, March 7, 2022, all refill and renewal prescriptions subject to the New York State Drug Formulary. Healthcare providers will submit the HP1 online to request board action for unpaid medical bills.
And for phase 2, as of April 4th, 2022, now the DME PARs are now being submitted using Onboard. These requests use DME fee schedule and the guidelines as of January 19th, 2022.
And then we already, this month, May 2nd, we got into phase 3, which is treatment/testing PARs, accepting the medical treatment guidelines and non-medical treatment guideline PARs. So the MG1 is now an MGT confirmation request. MG2 is an MTG variance PAR. C4 auth is an MTG special service PAR. Non-MTG PARs, that's over $1,000 for non-medical treatment guidelines sites. That's the old C4 auth for $1,000 or more treatment. Non-medical treatment guidelines under or equal to $1,000 PARs, which is new. That's used for requesting treatment that costs less or equal to $1,000. And that's optional for medical providers to use, but if the provider does submit one, then the payer must respond. And then all the MTGs became effective, and we'll be getting into those shortly.
Now, an important additional change to keep in mind is that the request for further action, or the RFA, will now be accepted online, and that will become mandatory on June 6, 2022.
Yeah, that's a big change even for our office. We're used to filing the paper version, so everybody's going to be filing the RFAs online now as of 6/6/22. So as payers, there's a lot of forms that, well, like we said, are going away. So Form HP1 was gone in March, the MG2 for medical marijuana, March, and all other forms ended 5/2/22. The mandatory response time for these requests, really nothing has changed. It's very similar. So as you'll recall, the MTG confirmation, which is the old MG1, 8 business days. The MG2, which is now, well, excuse me, MG2 and C4 auth, which are now the MTG variants, and the MTG special services, the same, 15/30. So you must respond in 15 days within receipt of the request, but if you're getting an IME or a record review, you must notify in 5 days and have that report within 30 calendar days. Non-MTG over 1,000, still 30 calendar days. Non-MTG under or equal to $1,000, which is the new one, it's 8 business days. Medication, 4 calendar days. Durable medical equipment, 4 calendar days. So note that the general rule is is either calendar days or, well, not the general rule, let me start that over. There's either the calendar days or the business days. So everybody needs to be, that's something to be very aware of. And 21 business days for the claimant to request review from the payer's decision.
Now, how the different PAR types other than medication undergo the PAR review. Now, if payer's level 1 reviewer approves the request, then the provider is notified. If payer's level 1 reviewer can deny for administrative reasons without a medical review, and if denial is based on medical reasons or burden of proof, level 2 reviewer required to review the request and provide medical rationale within the timeframes for the PAR type. Now, an IME can be used, but does not replace level 2 review. Provider can treat per the decision from the level 2 review or request a level 3 review by the board. Now note that the denial of the non-MTG over $1,000 PAR will be addressed at a priority hearing scheduled by the board. Also note that administrative denials are not eligible for level 3 review except for those for medication. Now, as for the medication PARs, Provider notified of the decision made by payers level 1. Provider either agree or submit a request using Onboard for a level 2 review by payer's physician. If level 2 review is requested, provider will be notified of level 2 reviewer's decision. The provider can agree with payer's decision or using Onboard to request a level 3 review from the medical director's office or the MDO.
And Onboard, and now the MTGs. So as we're all aware, there's a handful of new MTGs, the eye disorders, traumatic brain injury, CRPS, PTSD, depression. So in discussing the medical treatment guidelines, it's important to start at the rule itself, which is right here, 12 NYCRR 324.2. A couple of things to take from this paragraph slide. Regardless of the date of accident or disablement, treatment of the on-job injuries, illness, occupational disease shall be consistent with the applicable medical treatment guideline. Operative and medical treatment guidelines shall be the medical treatment guidelines in place on the date on which the medical services are rendered. So it might be a while before we get some reported cases of the new guidelines being applied. And amendments to 324.2 were adopted and incorporated into the medical treatment guidelines. So in this part of the presentation, we'll go over the new MTGs that came into effect May 2nd, 2022, from an overview standpoint, coinciding with the launch of Onboard, provide a general overview of the MTGs as well as some key issues, red flags, things to look out for, share some case law that demonstrate how these conditions have been handled until now, and see what sort of changes the new MTGs might bring about. So the first one we have is eye disorders. One thing that sets up eye injuries apart is their etiology or cause is non-controversial because the eye is very sensitive to pain. It's obvious when something's wrong, right? Typically, eye conditions fall under either acute injury or an ocular disease. Acute injuries have fairly simple mechanisms and require a straightforward treatment approach. However, a detailed history is essential because incorrect or misleading information can lead to blindness. A detailed description of the accident and its circumstances are required. If a chemical is involved, a detailed information on the nature of the chemical is absolutely essential. Ocular diseases and disorders may present with intense ache and pain, but could be caused by sinusitis, cluster headaches, or ocular migraines.
Now to discuss some red flags with eye diseases, and seeing if there's any red flags is the first step in assessing an eye injury. And red flags are defined as a sign or a symptom of a potentially serious condition. So some examples of red flags include sudden onset of loss of vision, photophobia, flashing lights, painful eye, and trauma, and warrant immediate referral to an eye specialist. But in the absence of red flags, experienced healthcare providers can safely and effectively handle most work-related eye injuries. Detailed history is essential in determining whether an ocular disease such as glaucoma is present.
Interesting. So some case law, a review of case law related to eye injuries and eye diseases confirms that the MTG states which is that the cause of most eye injuries is non-controversial. Case law appealing findings on eye injuries and diseases are therefore pretty sparse. But what seems to be the trend in eye cases is that eye injuries are easier to establish than eye disorders because of the mechanism of injury can be directly linked to the symptoms of an eye injury. On the other hand, many of the cases on occupational diseases for eyes demonstrate the high threshold claimants must meet in order to establish their claim. This is an example of a case involving an eye injury, matter of Diversified Automotive Inc. Here, the board panel affirmed a worker compensation law judge who found sufficient evidence to amend the claim to include convergence insufficiency. The claimant sustained trauma to his head and eye when boxes or totes fell on top of him, injuring his head and nose. The claimant specifically indicated on a C3 form that he injured his right eye due to the trauma. The doctor tested the claimant for convergence insufficiency and noted that the claimant had insufficient eye movements, vision dysfunction, headaches, and blurry vision. The doctor testified that these findings would be consistent with the history of the claimant's accident and that claimant's inability to focus is consistent with convergence insufficiency, which appears after a trauma most of the time. This case is pretty straightforward example of how trauma from an accident led to an eye injury, which was confirmed by medical testimony. The impact of the boxes falling and hitting the claimant's eye was found to be the cause of the claimant's inability to focus his right eye. Here's an example of a case involving an eye disease where there is no specific accident or trauma that can account for the eye injuries. Such injuries become more difficult to establish. So in matter of Suffolk County, a claimant worked as a boat ambulance driver transporting sick patients and experienced difficulty with his vision. Both the treating physician and IME consultant agreed that the claimant had ocular tuberculosis, which affects the retina. While it was likely that the claimant was exposed to tuberculosis due to his work, because he did not know whether any of the patients he had transported had tuberculosis, and therefore could not pinpoint a specific accident or incident where the transmission occurred, and the board panel disallowed the claim. Now here, both the treating physician and the IME agreed that the vision problems were due to ocular tuberculosis, but because the claimant was unable to prove the instance that led to the transmission of the disease, the claim was disallowed. In this case, in some ways, eye disorders leading to vision problems are very similar to hearing loss claims, where the board must be able to find that the work itself was the cause of the eye disease as opposed to degeneration due to advanced age. Now here in matter of Bendall Industries, in a controverted claim for loss of vision in both eyes from exposure to dust and air particles over the course of time at work, claimant saw one doctor who diagnosed him with dry eye and saw another doctor who diagnosed claimant's watery eyes as being possibly allergic in origin. Claimant worked as a welder for 9 years and did not wear safety eyewear. Claimant claimed his work did not provide him with any safety eyewear. The worker compensation law judge did find sufficient prima facie medical evidence of an occupational disease to the eyes. The IME consultant found the claimant to have presbyopia or farsightedness, likely due to his age. The judge disallowed the claim. On appeal, the board panel found that the claimant was not credible and affirmed the worker compensation law judge's findings. What this case highlights is the fact that the eye is a structure where abnormalities tend to be easier from an ophthalmologist to see. Scratches to the surface, retinal injuries, cloudiness, etc., can often be visually confirmed by a doctor. Where claimant's physical eye examination does not comport with claims of vision loss, the board is unlikely to find in favor of the claimant. The new medical treatment guideline primarily focuses on diagnosis and treatment of traumatic eye injuries rather than ocular diseases. This is perhaps one of the more straightforward medical treatment guidelines because eye injuries such as corneal lacerations and burns are relatively easy to assess, and the use of specific treatments such as eye drops or other medications are indicated. Now remember that when it comes to the eye, impairment is determined by 3 factors: loss of uncorrected or corrected visual acuity for objects at distance, visual field loss and diplopia or double vision, and vision is imperfect without the coordinated function of all 3. Now, things to keep in mind, the mechanism of injury, the who, what, where, when, how, why is always extremely important in establishing a workplace injury. Ocular injury is straightforward. Ocular disease is more difficult to diagnose. With ocular diseases, make sure that the specialist examines the claimant to rule out any underlying disease and the nature of that disease to determine causal relationship.
Now, moving on to traumatic brain injury, the next new MTG that we're going to discuss. Now, we're going to begin our discussion of TBI with some terminology and differentiation. A lot of times these terms are used interchangeably, but there are subtle differences. For example, concussion versus post-concussion syndrome. We often run into claims that involve concussions and post-concussion syndrome. And according to the Mayo Clinic, most concussion symptoms can last days, weeks, sometimes even months. When the symptoms last beyond the expected initial recovery period, it is called a post-concussion syndrome, or PCS. Now, this does not mean that PCS cannot manifest in the form of new symptoms. The MTG notes that some patients report new, persistent, or worsening cognitive symptoms weeks, months, or sometimes even years post-injury. Now, some more terminology: concussion versus TBI. What's important to remember is that concussion is a mild TBI. A TBI is classified as mild, moderate, or severe. A mild TBI does not require unconsciousness, or if the claimant was unconscious for less than 30 minutes. Memory loss lasted less than 24 hours, and the claimant scored 13 to 15 on the GCS, or the Glasgow Coma Scale. With a moderate TBI, unconscious for more than 30 minutes and up to 24 hours. Memory loss between 24 hours to 7 days, and the GCS score being 9 to 12. With a severe TBI, the claimant is unconscious for more than 24 hours, memory loss longer than 7 days, with a GCS score of 8 or lower. Now, with a mild TBI or concussion, again, loss of consciousness is not required, and there could be memory loss associated even with a mild TBI.
Thanks, Suki. Some symptoms of TBI. This table is from the Medical Treatment Guideline that lists some of the common symptoms of TBI, which can include physical, cognitive, behavioral, and sleep-related symptoms. Again, even with a mild TBI, these symptoms can persist for weeks or months. One important note is that the TBI can lead to motor function issues, such as weakness in the extremities, which can be associated with the neck or back injuries, which commonly presents in conjunction with head injuries. Another issue that commonly arises involves the behavioral symptoms, which can also be associated with psychological injuries such as depression or anxiety. So, the causes. TBI is defined as a form of acquired brain injury and occurs when sudden trauma causes damage to the brain. Trauma may include the head being struck by an object, head striking an object, the brain undergoing an acceleration, deceleration movement without direct external trauma to the head, a foreign body penetrating the brain, and forces generated from events such as a blast or explosion or other forces. Are just some examples.
Now, some red flags to look out for. These red flags may raise suspicion of serious underlying medical, neurological, and/or orthopedic conditions. Some red flags include increased intracranial pressure, intracerebral hemorrhages, central nervous system impairments, fracture, substance abuse with risk of withdrawal, progressive neurologic deficit, or myelopathy. Again, these red flags may point to underlying medical conditions or be symptoms of a separate issue unrelated to the brain. For example, with progressive neurologic deficit, there could be progressive limb numbness or weakness, bowel or bladder control impairment, gait ataxia, all of which could be due to a physical injury to the back or spine or have some other underlying cause.
Interesting. So the diagnosis, medical history, and physical examination are absolutely required. As TBI clinical presentations are so varied, comprehensive medical histories and physical examinations are necessary to assess the patient's TBI. The diagnostic approach needs tailoring to the specific claimant, particularly to factors such as the claimant's exact mechanism of injury, age, past medical history, underlying medical conditions, and prior injury history. Diagnostic imaging. The best way to assess TBI is an MRI, which the MTG states is superior to a CT. The CT is not recommended for diagnosis and treatment planning of TBI. So certainly be on the lookout for claims where there's a TBI and the diagnosis is based on a CT and there are no MRIs. That certainly would be suspect. And Suki had mentioned it in the red flags about like increased intracranial pressure and hemorrhages. So certainly an MRI is the superior method to diagnose that. Neuropsychological assessment. The MTG specifically recommends neuropsychological assessment for traumatic brain injury claims. Neuropsychology is a special branch of psychology that evaluates neurocognitive dysfunction. Right? So in general, neurologists are doctors who assess, diagnose, and treat disorders of the nervous system. They usually help with chronic headaches, migraines, sleep issues, other neurologic diagnoses like epilepsy or multiple sclerosis. Or they may help people who have brain damage due to car accidents or other types of trauma. A neurologist use a variety of tools to perform their job, such as an MRI, which we discussed, observation and examination to measure factors like the patient's reflexes, senses, brain function. Neurologists are usually focused on medication for treatments for these conditions. Neuropsychology involves assessing and treating a wide range of neurobehavioral problems of the central nervous system, according to the American Psychological Association. They are primarily interested in the relationship between the brain and the behaviors. So unlike neurologists who provide primarily medication treatment for the physical symptoms and causes of brain disorders, neuropsychologists treat the cognitive, mental, and behavioral effects of brain disorders without the use of medication. They perform neuropsychological evaluations and psychological tests, as well as offer specific interventions based on the claimant's concerns and problems. Neuropsychology employs assessments that frequently consist of a thorough clinical and neuropsychological assessment of TBI and various types of tests and test batteries to identify abnormalities related to the TBI. These tests typically undergo frequent revisions, and the most up-to-date version of the test should be administered. Normally, patients are given a battery of tests in numerous different domains, including but not limited to intelligence, memory, executive function, speech, language, visual, spatial, to assess impacts of and plan treatment of the TBI claimants. Now, given that the MTGs specifically call for a neuropsychologist as opposed to a neurologist, there's a need to look out for who's providing the assessment and diagnosis of the TBI. Consultants should therefore be neuropsychologists, not neurologists.
Now for the treatment of a traumatic brain injury. The short answer is there's really no treatment for TBI itself, since it's a brain injury and the only thing to do is wait for the brain to heal. Therapies to support and encourage healing, as well as rehabilitation from functional deficits, are recommended by the MTG. Such therapies can include occupational therapy, physical therapy, strengthening exercises, neurocognitive behavioral therapies, vocational rehabilitation programs. Use of medication is recommended to treat physical symptoms, mainly headaches, as well as behavioral symptoms such as depression and anxiety.
And some brief case law, again, these are obviously new, came out in effect for May, but in the past, TBI could be established without a specific diagnostic testing confirming TBI. So here in a matter of A+ Sheet Metal Inc., it's a 2022 board panel. The case was established for injuries to the neck, back, right knee, PTSD, depression, cognitive impairment, and a scalp contusion from a 2015 accident. The board panel amended the claim to include TBI since the carrier authorized and had been paying for treatment for cognitive therapy that included the diagnosis of TBI for years, and the IME conceded to treatment for cognitive therapy and specifically a diagnosis of a TBI. It's highly unlikely, or excuse me, it is likely that the new MTGs, the threshold for establishing TBI will be set higher because the MTG specifically calls for a diagnosis by a neuropsychologist.
Well, can I just talk about that for a second? So the neuropsychologist is not an MD. So would you need diagnostic studies initially in order to substantiate some sort of actual like physical injury to the brain in order for a TBI to be present? And then the neuropsychologist would come in to I guess, assess the severity of any symptoms that would result from that damage?
I think that's an accurate assessment, especially because TBIs tend to be caused by a physical injury to the head. Unless it's a whiplash injury, there has to be some kind of impact to the head. So yeah, a medical doctor would have to assess the physical injuries. And as for the extent of the brain injury, a neuropsychologist would come in and make that diagnosis.
Okay, but I think even with a whiplash injury, it's the brain hitting the skull inside the head, which is
Right.
the physical trauma. Okay.
Yeah.
All right, that makes sense. All right, thank you.
Thank you. That was a great question. And often TBI was associated with a delayed presentation, which brought up work compensation law section 28 issues, which require an injury claim to be raised within 2 years of the accident. Many TBI cases have hinged on a finding of section 28. An example, matter of Albany County Sheriff's Department. So the claim is established for work-related injuries to the head, neck, back, left elbow, right knee, post-concussion syndrome, cognitive disorder, and consequential mood disorder with depression and anxious features based on a work-related accident from 2010. The record was developed with submission of medical evidence, lay testimony, and medical testimony. WCLJ found that the doctor's testimony provided sufficient credible evidence supporting a finding that that the claim for TBI was barred by section 28 because the testing for TBI had been available for nearly 4 years before the TBI was raised. Claimant's argument, it's not time barred when the injury was not correctly diagnosed until more than 2 years after the accident, and the carrier had notice of the symptoms that led to the diagnosis of the TBI within the 2 years of the accident, and it paid for treatment. The self-insured employer argued the claimant failed to affirmatively state a claim for TBI within 2 years because the claimant made the claim 4 years after being tested for TBI. The board panel decided that prior medicals do not indicate claimant was specifically diagnosed with TBI, so the claim was not time barred under section 28, and the claim was amended to include a traumatic brain injury. I have a couple more cases, but for time's sake, I'm going to skip over them. They are in the slides. Some things to keep in mind, right? So most mild TBI resolves on its own within a few days and therefore does not require professional evaluation and treatment other than natural recovery. If symptoms persist for more than a month, even with a mild TBI, neuropsychology assessment would be recommended.
Now moving on to complex regional pain syndrome. Complex regional pain syndrome, or CRPS, is a rare chronic pain disorder affecting the upper or lower extremities. It is characterized by pain disproportionate to the intensity of the triggering factor and may have a later onset than the time of the harmful event. There are two types of CRPS, 1 and 2, distinguished primarily by damage to the nerve itself. Here are some key differences between CRPS 1 and 2. Now, with CRPS 1, sympathetic hyperactivity due to trauma to an extremity, such as a fracture, that doesn't include direct trauma to the peripheral nerve. And it usually involves the distal part of the extremity and occurs all around the limb. involves probably the peripheral nervous center and possibly the central nervous syndrome. Onset is usually a few weeks after the injury. The pain is described as a burning pain made worse by movement or touching the skin. Persist indefinitely if not treated. Patients can suffer from depression and social fears. Now with CRPS2, there's a burning pain, hyperpathia or allodynia of an extremity following a direct nerve injury. Can simply be symptomatic near the injury, but not the extremity all around. Can occur immediately following the injury or months later. Constant burning pain made worse by light touch, movement, change in exercise, and stress. Risk of suicide and drug abuse if left untreated.
And just briefly, I mean, in my practice, I've seen a lot of CRPS claims, and I would say doctors just try to blanket it with CRPS. And when I pressured them into either one or two, they kind of fall apart. So I think it's interesting, or a good idea at least, that the treatment guidelines give out some criteria for CRPS. Diagnosis. To make a clinical diagnosis, the following criteria must be met. The claimant must have continuing pain disproportionate to any inciting event. They must report at least one symptom in report at least one symptom in 3 of the 4 following categories. We have sensory, vasomotor, pseudomotor, and motor trophic. The claimant must display at least one sign at the time of evaluation in 2 or more of these categories. They're the same as above: the sensory, vasomotor, pseudomotor, motor, and trophic changes. There is no other diagnosis that better explains the signs and symptoms. As the criteria and the name of the syndrome demonstrates, this is a very complex and specific condition that is often difficult to diagnose. It is important to distinguish CRPS from non-acute pain. In the simplest terms, CRPS is chronic pain disorder, whereas non-acute pain is a chronic symptom. CRPS should be confirmed by a trained physician. Most commonly reported after traumatic insult or major symptom insult like a stroke. Relatively infrequent occasions where the cause is unknown. Females diagnosed with CRPS 3.4 times more frequently than males, and the incidence highest among 50 to 70-year-old people. Much like other conditions, initial assessment involves a thorough history, a physical examination. However, what is different with the assessment for CRPS, what is different for the symptoms of CRPS is to exclude other potential explanatory conditions by closely examining the history of symptoms, the trauma, the purported cause of the symptoms, the treatments attempted, and exercises performed.
Now a little bit about the symptoms of CRPS. Symptoms and signs may include constant severe burning or throbbing pain, typically isolated to one limb. Trauma often precedes symptoms, and symptoms are disproportionate to the trauma. There's non-radiating pain, significantly worsening pain with activity, sensitivity to touch, unusual sensitivity, and pain to minor pressure or palpation. Skin coloration changes, including blanching and mottling. Now, the treatment for CRPS, interventions for treating pain should be time-limited and functional goal-oriented. Identification of psychosocial issues should be part of the initial evaluation for CRPS. The overwhelming theme in the treatment of CRPS is to keep the patient as physically active as possible. To achieve this, activity and work modification is encouraged. Strengthening, conditioning, and aerobic exercises are very important. Now, medication use is recommended for sufficiently severe CRPS. First line should be over-the-counter pain medication. Even in patients without depression, antidepressants may be recommended if there are sleep issues. In extremely rare cases, surgical options such as spinal cord stimulators for short to intermediate term relief should be considered, but the patient must meet rigid selection criteria. Again, the primary treatment for CRPS is rehabilitation, physical therapy, occupational therapy, and a home exercise program.
So some things to look out for. Red flags for CRPS have to do with potentially serious conditions associated with chronic pain that require further investigation. When the medical history suggests pathology originating in a location other than that originally injured, it may require investigations that would not appear to be related to the work injury, but would nonetheless need to be performed. What this means is that often what the doctor is looking for is not the cause itself, but rather signs of the underlying cause, such as a tumor, infection, progressive neurologic deficit, cerebral pressure increasing, rheumatologic disease, and psychosocial causes. Okay, so we've talked about how important it is to obtain a history, especially here in this MTG. Details of the event, what the doctor is looking for are unusual and disproportionate pain compared with the degree of injury, right? So I suppose if somebody got a paper cut on their finger and was treating for it under workers' comp, if there was unusual amount of pain, that would be probably disproportionate. The occupational history and patterns of daily living, not only to provide context for the injury event, but also provide motivational tools to facilitate the patient's functional restoration. After the function-based and pain histories are obtained, the history should next include a thorough medical history, past medical history, medication history, surgical history, accident history, current psychological history, and past psychological history. Now, the biopsychological approach, CRPS cannot be explained by traditional medical model of acute injury resulting in pain and tissue damage. For acute pain, inactivity may reduce the pain, but for chronic pain, recovery is usually dependent on physical activities. The model views disorders such as chronic pain due to CRPS as the result of dynamic interaction among physiological, psychological, and social factors which perpetuate and may worsen the clinical presentation. I do have some cases in here, but I'm just going to do one of them to keep it on track, which I'm already behind. Perhaps the CRPS MTG will have the most significant and immediate impact on claims involving chronic pain moving forward, because it serves to define CRPS and outline treatments specific to the condition. In the past, because this condition involves chronic pain, often the non-acute pain MTGs was applied because pain management was the primary focus of the CRPS treatment. One case, matter of strategic outsourcing, Inc., the 2019 board panel. Treating physician found causally related CRPS years after the work-related accident in the right lower extremity. The doctor stated the diagnosis confirmed because claimant had been receiving right lumbar sympathetic block sedation. Claimant was on gabapentin and Percocet from the outset of treatment. IME did not find any CRPS, but recommended it continue pain management. IME testified that the claimant did not meet the criteria because he did not have hypersensitivity commonly found with CRPS. Nevertheless, the WCLJ amended the claim to include right foot CRPS, denied the carrier's request to direct weaning off of Percocet. The board panel affirmed, finding that the LSD treatment confirmed the CRPS diagnosis and looked to the non-acute pain MTG to determine claimant was not a candidate for weaning. There's another case which is included in the slides. Things to keep in mind. Really, observation is a key component of the physical examination and should begin upon the patient's arrival. how they arrive, how they move in the waiting room, how they walk, how they get up from a seated position, how they get on and off the examination table should all be recorded. CRPS usually involves non-dermatomal pain, which means sensory deficits that don't conform to the distribution of the peripheral nerves, and usually present with allodynia or a type of pain that is sensitive to touch. CRPS is a specific condition with a specific diagnostic criteria. It is not a catch-all for persistent unexplained pain disproportionate to the injury. With CRPS, pain does not equal injury, and the best treatment is to return to work and lead as normal of a life as possible. Use of the affected extremity will not exacerbate the symptoms or worsen the injury.
Now we move on to PTSD and acute stress disorder. PTSD and ASD, acute stress disorder, are psychiatric disorders that can occur in people who have experienced or witnessed a traumatic or terrifying event. Experiencing actual or potential severe injury, life-threatening circumstances, physical or sexual assault, or other extreme social or natural events. Now, ASD occurs when symptoms persist for 3 to 30 days after a traumatic event. If symptoms persist beyond 30 days, a PTSD diagnosis may be considered. Because ASD is clinically defined as limited in duration, it often does not come up in workers' compensation cases.
PTSD requires the following criteria for a diagnosis of PTSD. Listing all the diagnostic criteria not only gives us an idea of how complex PTSD really is, but how high the threshold for diagnosis is under the DSM-5. This information is available in further detail in Table 2 of the Medical Treatment Guidelines. So, as mentioned, there are areas of criteria that are required. So, a stressor. One is required. The person was exposed to death, threatened death, actual threatened serious injury, or actual threatened sexual violence, either direct exposure, witnessing it, learning that a relative or a close friend was exposed to a trauma, indirect exposure to adverse details of the trauma, usually in the course of professional duties, such as first responders, medics. So the only one there that I don't think you would really see is learning that a relative or a close friend was exposed to trauma. I don't necessarily see how that would be work related unless they were working with you, I suppose. But moving on, for criteria B, intrusion symptoms, that would be the traumatic event is persistently re-experienced in the following ways: either unwanted, upsetting memories, nightmares, flashbacks, emotional distress after exposure to traumatic reminders, physical reactivity to exposure to traumatic reminders. Criteria C, avoidance. Now, avoidance of trauma-related stimuli after the trauma in the following ways: one, not both, but both obviously might be present. Trauma-related thoughts or feelings, trauma-related external reminders. Criteria D, negative alterations in cognitions and mood. You have to have two of those. Negative thoughts or feelings that began or worsened after the trauma in the following ways: inability to recall key features of the trauma, overly negative thoughts and assumptions about oneself or the world, exaggerated blame of self or others for causing the trauma, negative affect, decreased interest in activities, feeling isolated, difficulty experiencing positive affect. Criteria E, alterations in arousal and reactivity. Trauma is related arousal and reactivity that began or worsened after the trauma by irritability or aggression, risky or destructive behavior, hypervigilance, heightened startle reaction, difficulty concentrating, difficulty sleeping. Criteria E, or that was the E. Criteria F is duration. Its symptoms are required for more than 1 month. G, functional significance. The symptoms create distress or functional impairment, i.e. social, occupational. And criteria H is symptoms are not due to medication, substance use, or other illnesses. So when you're evaluating a case and determining if PTSD would be present, this is a great outline, right? We can go right through it, and if there's something missing from the claimant's history, a lot of times what we can do then is for our IME, we would probably point that out to the doctor so that we could, see if it's existing or not.
I'm also going to just suggest that we make that argument at the time that the judge is considering whether or not medical evidence suffices as prima facie medical evidence, because it's easier to, nip it in the bud rather than have to litigate it.
That's a great point, Melissa. So even at the hearing level, when you're preparing for a case or sending over directions, and ourselves as well, reviewing it, we can see if one of the criteria are missing and the claimant doesn't meet it. There's a great argument right there that medical report wouldn't even rise to the level of PFME. So it's a great point, Melissa.
Now, very quickly about the treatment for ASD and PTSD. For ASD, even though not every ASD diagnosis leads to PTSD, provision of cognitive behavioral therapy in the acute phase is the best strategy to limit subsequent PTSD. Now, with PTSD, primary initial intervention is again cognitive behavioral therapy. And in some other less prescribed therapies include exposure therapy, virtual reality training, and EMDR.
Right. Thank you. And we do have some cases, but I am really running short on time. So let me just say that in some cases, the DSM has been relied upon for a basis of finding PTSD. But with the MTG being established, it will be interesting to see how stringent they will be with the adherence to the diagnostic criteria, since under the DSM and now the MTG, there technically can't be a diagnosis without meeting all the criteria. We have seen plenty of stress cases where the claimants have to prove that the stress was excessive, extraordinary in order to establish the claim. And likely that will remain the case even after incorporation of these MTGs. Even if a claimant meets all the diagnostic criteria, that claimant still must show that the incident causing the PTSD was out of the ordinary. Now, things to keep in mind for all psychological and psychiatric interventions, there must be an assessment and treatment plan with measurable behavioral goals, timeframes, and specific interventions planned. For psychological intervention, optimum duration is 3 to 6 months and maximum of 9 to 12 months. For treatment, documentation of the nature of the physiological factors as well as projecting a realistic functional prognosis should be provided by the treating practitioner every 4 weeks during treatment. So really, it's something that we can monitor to make sure that this is what's going on, this is what should be happening if there is this claim for PTSD.
And now moving on to depression. The DSM-5 criteria should be used to diagnose depression and depressive disorders. Establishing a working diagnosis entails a focused clinical interview, physical examination, and pertinent lab and other testing. The MTG for depression includes the diagnostic criteria for the following disorders: major depressive disorder, more on that later; depressive disorder due to another medical condition; evidence from history, physical exam, or lab findings that disturbance is the consequence of another medical condition; adjustment disorders, marked distress out of proportion to the severity or intensity of the stressor; or substance and medication-induced depression, symptoms of the depression developing during or soon after substance intoxication or withdrawal, and the substance involved is capable of producing such symptoms.
So a deep dive into major depressive disorder, MDD, is most commonly encountered depressive disorder in worker compensation cases and is often as a consequential condition secondary to persistent pain. There are criteria that must be met. It goes through A through E. try to speed it up a little bit. The criteria A requires 5 or more of the symptoms listed that have been present during the same 2-week period and represent a change from previous functioning. Criteria B, symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. Criteria C, episode is not attributable to the psychological effects of a substance or to another medical condition. Criteria D, episode is not better explained by schizoaffective disorder, schizophrenia, another one, delusional disorder, or other psychotic disorders. Criteria E, there has never been a manic episode or a hypomanic episode. So one thing to note in the criteria for depression is that it is not limited to subjective complaints by the claimant, but also incorporate observation by others. The emphasis is on change in behavior brought on by the original workplace injury. So just briefly touching on that, I think a great question that we would need to know then is, when we're maybe deposing a doctor, would be, did the claimant report any of this? Did the claimant's spouse or anybody in their family note any changes? Sometimes, they'll bring their spouse with them. So that's interesting. And also, moving on to treatment.
Now, the treatment for depression, the most common treatments are cognitive behavioral therapy and pharmacotherapy with antidepressants. Now, often claims involve payments for cognitive behavioral therapy. So what is CBT? CBT is when therapists teach patients how to develop effective coping skills. Patients experience difficulties because of faulty thinking and behaviors. CBT helps to identify and change negative thought patterns. Now, with pharmacotherapy with antidepressants, it's for individuals who are also treating underlying injuries or medical conditions. It is vitally important that the drug-to-drug interaction with any antidepressants or other medication is considered.
It's important to keep in mind the existence of pre-existing depression and whether that depression is the cause of the current symptoms. In Matter of Manpower, the issue was whether the claimant suffered a consequential transient aggravation of the claimant's long-standing and pre-existing depression. A treating pain management physician opined that the pain the claimant had from her work-related back injury was contributing to the claimant's depression. The IME disagreed and opined that the claimant suffered a brief aggravation of pre-existing depression immediately following the accident date, but noted that the brief aggravation had resolved soon thereafter. The WCLJ amended it to include transient aggravation of the claimant's longstanding and pre-existing depression. The board panel found that even thought the claimant returned to the status quo after suffering temporary aggravation of the pre-existing depression, there was sufficient nexus between the initial work-related injury and the subsequent temporary aggravation of the depression, and affirmed the decision. Aggravation of symptoms did resolve, but they still included depression because the new MTGs rely so heavily on the DSM, which requires symptoms to be occurring nearly every day. It will be interesting to see whether symptoms that have resolved will still be grounds for finding of depression. Some brief things to keep in mind. In the past, WCLJ could weigh the credibility of a treating physician and consultant's opinions, but now the MTG calls for certain criteria to be met, of course, still with being able to weigh the credibility of the treating and consulting opinions, but now with a guide. Often diagnosis is based on one consultation that does not discuss how the behavior is a change from previous behavior or the onset of the behavior. The DSM-5 is more concerned with these changes, so make sure to be on the lookout for the initial consultation that does not discuss how the symptoms represent a change in the prior behavior. Be on the lookout for pre-existing depression that predates the workplace injury. With regard to treatment, be on the lookout for CBT that goes beyond the 12 to 16-week mark, and make sure the therapy is showing some effectiveness. With medication, bear in mind that some patients will have to take antidepressants indefinitely, and those that can discontinue use must be tapered off the medication. And it is 1 o'clock. And Suki and I were going to go through the updated medical treatment guidelines. What we were going to be highlighting here are they're not the changes to the updated, but rather selections of relevant and interesting treatment options for injury sites we're more familiar with. But we did not get to it. So, well, it's that time. I'm trying to jump to the end. Suki, do you have anything you want to jump in and talk about?
No, I don't think so.
So you guys, you tackled an extremely broad category of new guidelines for us, and certainly putting your arms around that much material was definitely difficult. But it looks like your slides are a great resource for people, and so if they would like a copy of your presentation, we certainly could provide it to them, especially if they have an interest in one of the additional sites that you weren't able to get to. And I would also encourage people, if they do have any questions regarding the additional sites, which would include the shoulder, the neck, the back, and the knee. What else?
Non-acute pain.
Non-acute pain, that I'm certain that Neil or Suki would be pleased to accept your email or your phone call and field any questions that you might have. So I really appreciate all the work that you did. Is there anything else that you wanted to say as we wind up for today?
Just briefly, I mean, we did go over a lot of the new MTGs. We didn't get into the other ones, but one thing I think it's going to be a good thing in a sense of, I don't know about reducing or increasing litigation, but it certainly gives a more clear outline of what to be looking for when somebody is claiming depression. I have seen it like just so many times, or PTSD, and you're looking at it and you're like, there's nothing in this report doesn't meet the DSM, and the judge still was just like, well, that's kind of just the way it is. So I'm hoping that this really, I think it will give a good guidance to defending the claims, as well as to the judges to look at that. And thank you, everybody, for joining us.
Thank you very much for the work you guys put into the presentation. It was great. All right. Take care, everybody, and we'll see you next month.